Welcome everyone, and I'm Adrian Schoo, and this presentation is going to be on how we can build capability amongst health professionals to work interprofessionally together, and we approach this from a complexity theory perspective. So if we look at factors considering a crisis situation, like, for example, what we at the moment facing with the corona, and also in the past, of course, where we had to cope with different challenges in healthcare, there is a sense of urgency. And of course, there are political directives often as well to try to contain the crisis. We need the resources, logistics, we need good leadership, and you can see there's a lot of factors we need to keep in mind that we need basically to adequately respond to a situation. And of course there are barriers and enablers as well, what we need to identify, and we need certainly to be aware of wicked problems. And wicked problems are problems that are any solution to that will create another problem. So we need to be aware of that. And a good example, for example, is, now with the coronavirus, when imposing social distances to slow down the infection rate is there to protect the people, and of course also the healthcare as a system. But at the other hand, on that's then one aspect that's maybe a good thing, but on the other hand, it will create some economic turmoil and chaos, and that's the other side of it. So I think indeed, and sometimes if we think about the environment and other things may even be more complex. So in that sense, I think we need to be aware of, and we need to educate health professionals, students who are becoming health professionals, to think, how can we create win-win situations? How can we reduce the damage? How can we indeed benefit, even though some things may be compromised? We never have an ideal solution for things, but at least that people can sort of start to have the ability to do that. So in that sense, my argument is as well that we need to go beyond competence as an educator. We need to start to build capability, and I'll come back to that later on. But first of all, to do that, what is important is that we can start to learn systems thinking. And that's a concept coined by Peter Senge in his book of the 5 disciplines of a learning organization. And systems thinking is basically to understand, it's like a sort of a mindfulness and thinking, what are basically the ingredients? What are basically the players who come into play, so that we can start to understand the system and the interconnectedness of it, right? That's quite an important for us to know, so that we know then also where we can possibly change and how we can get some support. So I think taking that a step further, we have to recognize the complexity of healthcare systems before even considering calamities that may occur, crisis situations. So if we look even normally what's going around in a healthcare system, we need to think about the clinical microsystem, the departmental level, where we have got competing demands related to clinical service provision, limited professional development opportunities impacting on job satisfaction, especially when you think also about health professionals who are located in rural areas, staff retention as a consequence, and also the recruitment of new staff who perhaps may not really want to work somewhere because of the compromised opportunities. And there is also the desire to innovate, and we have got lots of ideas, but there can also be limited organizational support to do so. And then on the level of the meso system, the organizational level, we also have factors like groupthink, where, for example, one group of health professionals thinks they are more important than other ones, and where also their thinking may be unchallenged, resulting in very compromised outcomes. So there might be also limited flexibility for interprofessional learning. We only have to look at, for example, universities, how hard it is for for academics to synchronize to the classes, for example, that the timetable, so that students can learn together, right, and from different disciplines. So it can be quite difficult, and it's also in healthcare settings, like as in hospitals, that can be quite difficult as well. And of course, the career pathways, the research culture. Some clinicians may think that research is not really that important, but there's also evidence that research culture is very important as in achieving optimal outcomes and staff satisfaction. So again, there are a lot of factors, as you can see for yourself. On the macro level, the socio-political level, we have got silo structures and funding issues, and silo structures as well. For example, we know that sugar is not quite a healthy thing. We know that it's causing inflammation and other things, and we can sort of say, as the Department of Health, we need to limit sugar intake, or we can use price elasticity to make sugar more expensive. But on the other hand, does the Health Department also talk to the Department of Agriculture to see what they are doing with the sugarcane growers, you know, or the producers of sugar? So again, we need to recognize the complexity and the different players, that the different stakeholders. So again, that brings me to the next point then. If we look at these three levels, who are the stakeholders and what drives them? What drives them in a complex environment, how can we achieve then win-win situations? And if we achieve a win-win situation, are these outcomes then be sustainable? And what happens if one stakeholder is more dominant and dictates the processes? Just as I mentioned before, groupthink, where one group of health professionals might think they are more important than other ones. So do we then achieve outcomes that are perhaps acceptable and the best outcomes for the health consumers? So again, I think we need also then to look at health literacy. The consumers, are they aware of the issues, and so that they can support the guidelines, that they can adhere to the advice being given to them. And and then we need also to look at who are the leaders when considering readiness for interprofessional practice and evidence-based practice, and function in complex adaptive systems, because they are dynamic and always changing. So that's that brings me to the point, what are complex systems? And I think in that sense, I think we need to understand that everything is changing, nothing remains the same. So complex systems are relational, relationships are quite important, that dynamic. And the agents within a system are the patients, the health professionals. If we look at the health system, students, teachers, administrators, universities, and so on, policymakers. So there's a whole complex web of interrelationships that shape how the system performs. And now you can understand as well that our communication skills are quite important to bring about change, to get people on their side, on our side, or perhaps to realize and to reflect perhaps that other people might have a point as well. So relationship communication is quite an important skill, and leadership and also self-leadership. So there are new things coming up all the time, so they might emerge, right? New inventions and machinery, but also new professions and the way they work together, the new treatment methods. So interdependence and distribution of power and authority, and diversity of knowledge and expertise, and so on. So again, it becomes quite complex. So I think if we then look at, from education point of view, we like to look at the clinical educator, who is at the interface between the universities and the health services. And they are basically giving the students the opportunity to learn, to develop their experiences in a complex environment. So that means also that if we translate then the previous to this situation, the clinical educator needs good communication skills, but also lots of other skills to increase their influence. Because there are a lot of things concerning us. If we look in terms of Stephen Covey, there's a lot of things that we can't influence. We can't influence that there is all of a sudden a virus and what the virus is doing. So, but we can influence that through a lot of different measures and working together to combat that. So I think if we look then at the 4 domains, we have got a societal domain where we get the community and the government, and the educational domain where we have got the universities and the students, and our personal needs and professional expectations, and also of course the patient and the clinical services. And then, as I mentioned before, we have got the micro level, meso level, and macro level. And again, there's a lot more things that we can identify, but again, it is, you can already see the complexity in this. And the more we understand that, the more I think we will be able to go to address the issues that need to be addressed in order to get to optimize outcomes. So who are the stakeholders for the clinical educator? So these are, of course, the health agencies in which they work, and they can be public or private. It can be primary care, aged care, the universities that place students in the region, the health professionals, clinical supervisors, faculty members. Again, they're often on the interface between the universities and the health organizations, so they can be a staff member of both. There can also be a staff member of the hospital who are still then liaising with the university and vice versa. So they also deal with special interest groups in the community, state governments, regional regions, and local governments. Depends also on what their role is, and also, of course, funding for new innovative models, like, for example, if we think about allied health in emergency departments, where, for example, physiotherapists will work and address most of the musculoskeletal issues, or in mental health, for example. But that means also that we need to pilot some research to show also the policymakers, the decision makers, that something like that can save a lot of money. So we also then require health professionals to understand some research and to be able then to be innovators as well. So it requires then different professions working together as part of an interprofessional practice. That's where innovation can start. That's where better practices can start, because they all bring in their own expertise, but they have to be able to communicate them well as well. And that's quite an important skill to have. So if we look then at interprofessional practice, it is only effective in preparing for complexity if we really know first again what it is. And we have different terms we can find different terms in the literature as well, including interprofessional learning. That's sometimes seen as an umbrella term for interprofessional education at one end, that occurs at the university level, and interprofessional practice that is perhaps occurring more in the clinical sense. The current literature refers to IPE as an interprofessional practice and education. So IPE occurs then when 2 or more professions, students, residents, health workers, learn together, right? They learn together with, about, and from each other to enable effectiveness, collaborative practice, and improve health outcomes. So the mechanisms then that shape interprofessional education and interprofessional practice, that if we look on the left side, if we look at purely from educational point of view, we need to have the champions, we need to have shared objectives. So there are mechanisms related to the educator. There are also mechanisms related to the curriculum, the development, how the curriculum looks like and what sort of principles they learn, for example, for example, adult learning principles, how they assess it. And there are different sort of forms of assessment now as well as part of a part of a whole course and program. So programmatic assessment is a new term, for example. Then interprofessional practice, it's also depends on institutional support, the work culture within an organization, and the environment in which that occurs. So then, of course, we have got the at the coal phase, where we have got the health and education systems coming together, where we look at different issues, and where we look certainly also at patient safety issues. So I think if we just line up the three, then we can see that in the first place, the educator and the curriculum mechanisms are basically represented through interprofessional education, and that prepares the students basically for interprofessional practice. But then when they really go into the work environment, we need the institutional support, we need a positive work culture as well, and the whole environment need to be conducive for interprofessional practice in order to achieve optimal health services and to achieve optimal patient safety. So in that sense, there need to be a responsiveness to crisis situations if they occur, and that's likely to be enhanced when people are capable instead of only competent. So that means that capability, if we look at that, is basically to be prepared for issues that perhaps you haven't been exposed to, but because of your wide experience in different settings and in different circumstances, you may have a good idea about what to do. So competence is only an observable performance about a particular issue. You are good at something, for example, in giving people an injection or a certain surgical procedure, and you might be competent in that. But capability is something that you haven't encountered as yet, but you're still able to complete that successfully. So if we look at then some of the barriers to interprofessional education and collaborative practice, lack of common interprofessional ground, power differences, as I mentioned before, in groupthink as well, where people are perhaps more protective in relation to their own discipline. So in that sense, profession-driven education can be a limitation as well, where they specifically might be concerned about sharing their own knowledge. And of course, professional structures and socialization. There are some issues we really need to recognize that could be possible barriers. So implications for interprofessional education and training, we have to foster mindsets that includes understanding the complexity of systems and how these articulate with the different micro, meso and macro level, understanding yourself as a health professional or as an educator in the system and recognizing the needs of others as well. And those needs can be slightly different as well. So we need to recognize also the uniqueness of that. And also we have to recognize the possible concerns, you know, like groupthink, what I mentioned before, and how can we reduce those barriers? How can we get those professions on side, right? And talking together and respecting each other and recognizing the ability, expertise that other disciplines may have. So I think then indeed recognizing the possible opportunities to build capability through interprofessional practice is very important. And then last but not least in that as well is understanding the impact of resonant versus autocratic leadership styles. If you work, for example, in intensive care, or we think, for example, now of the coronavirus, we might need to make autocratic decisions as a leader, as an autocratic leader, leadership style. We might have to adopt that for a short time to call the shots and to make sure that everybody is doing, that it's clear, that there's no conflict of information, that people may think this one thing or the other, or they might have different opinions. You really need to have people doing the same thing. But that means also as a leader at that time, like as an intensive care with a cardiac arrest, that you have got all the responsibility as the leader. There's no ifs and buts about it. You know, you are responsible for that. The challenge then is also after the event is to flip out of that and to adopt again a resonant and leadership style, because nobody will like to hang around too long amongst people with autocratic leadership styles, because they can't find themselves in that either. So I think it's quite important to make sure, and leaders need to be quite aware of that they know when they have to use a particular style. So if we look at the policy level, how can evidence-based policy then support complex adaptive systems and enhance systems thinking and collaboration between the different systems, and facilitate the leadership and innovation needed to optimize the effective and needs-based health services? And also, can policy then prepare students and health professionals to function successfully within complex systems, and can that lead to meaningful professional development and career pathways to enhance job satisfaction and retention of the health workforce? Especially also when we think again about the differences between urban settings and rural settings, as an example. So, and then also, can such a multi-level approach enhance organizational development, leading to organizational change and to optimize basically the responses in a crisis situation such as pandemics? So in conclusion, health professionals need to understand and analyze the complexity within which they work, so they can recognize the challenges in the system and identify opportunities to optimize their influence and reach. And healthcare staff and students, for that matter as well, need to work and lead in a way that best serves the consumers in a dynamic and complex health service environment. Education and training then needs to go beyond the acquisition of knowledge and clinical skills alone. So the argument is basically we need to aim for capability rather than only competency, to support innovation and build capacity and being prepared for possible crises. So complexity thinking can help healthcare staff leading teamwork and patient-centered interprofessional practice that can be sustained over time and under changing conditions, which could be supported by policy. And thank you so much for listening. I hope that this has been useful, and there's here some references that might be of interest to you. Thank you.